I'm Barry Losasso. I'm a pediatric surgeon at the Valley Hospital. Well, pectus excavatum is a quite common problem that if you know what to look for on any sunny day down on the shore, you'll see someone, generally a man or a boy, with their shirt off that has the condition. It's seen in 1 in every 350 to 450 people on the planet. It affects men and boys much more so than women and girls, in a ratio of 4 males to every 1 female. But the condition itself is caused by growth and having the genetic inheritance, the genetic predisposition to your chest wall growing in an abnormal way. What's abnormal is the ribs to either side of the sternum or breastbone are made of a special substance called cartilage, and it's different than the ribs on the sides of the chest and in the back of the chest, which is made of bone. So people with this condition, pectus excavatum or sunken chest, have the genetic predisposition for the cartilaginous ribs in the front of the chest to grow abnormally during the phase of growth in all of our lives, which is most pronounced in that sort of prepubertal time period from about 10 to about 16. And it's during that very rapid growth for people who have inherited this condition to start to see their chest sink and form almost like a bowl-like deformity, where their front of their chest and their breastbone moves ever slowly towards their spine. And in that happening, the heart becomes both compressed and displaced out of its normal position in the front of the chest, in the center of the chest, to a position that's more lateral, leftward, and much more sunken and compressed. And what happens to those individuals with that condition is that the heart works more inefficiently as a result. It doesn't hurt the heart. The patient's life is not shortened as a result of having this condition. But what it does do is affect the efficiency with which the venous blood returning to the heart can then circulate to the lungs, especially at times when patients are trying to be more active, when they're running or swimming or biking or hiking or doing things at elevation like skiing or snowboarding. It's in situations like that where patients start to become symptomatic, and those symptoms generally are shortness of breath and a lack of endurance, or an intolerance to exercise, as we call it. And so in those moments when people are trying to be their most active and hopefully enjoying life at its fullest, that's when they start to have symptoms. Symptoms, again, of shortness of breath, of fatigue, sometimes palpitations or a feeling of your heart skipping beats in your chest. You can have pain. It's generally mild. Pain is not a big component of the symptoms that patients have when they have pectus excavatum. And then, of course, that cosmetic deformity of a bowl-like deformity of the chest. Well, the Nuss procedure is the 21st century solution to having sunken chest. And the story really starts with Dr. Donald Nuss, a pediatric surgeon who worked his entire career at the Children's Hospital of the King's Daughters in Norfolk, Virginia, and someone who I consider both mentor and dear friend. I was fortunate enough to learn the Nuss procedure directly from Dr. Nuss. And over the course of a year, within a year of him reporting his first 45 patients to the world, I joined him in Norfolk and learned the operation directly from him. 15 years into my pediatric surgical career as a pediatric surgeon in San Diego. And so over the course of a year, I went to Norfolk and I learned not just how to do the Nuss procedure, but also how to select patients who would be good candidates for the procedure, how to then do the operation safely and effectively, and then help patients recover from the operation, which requires about 3 months to do so. So Dr. Nuss, working within his small group in Norfolk, came up with this brilliant idea of inserting a metal implant, a steel bar, that comes in different lengths, but is all the same thickness and width. And that implant needs to be bent by the surgeon to conform to the dimensions of the anterior chest, and then through the skill and experience of the surgeon, those implants are placed within the chest through very small little incisions on either side of the chest, using also a telescope called a thoracoscope to insert those implants in what we call a minimally invasive fashion. And it's sort of miraculous. You go into the operating room with a sunken chest, you have these bars implanted in your chest and secured in the proper position within the chest. And then, much like braces will straighten crooked teeth, these bars will literally reshape the chest and permanently cause the chest wall to assume this corrected position. And that's done within the context of a 4 to 6 hour operation. But the actual final result requires years of having the bars in place, and that those internal braces then permanently reshaping and reconfiguring the chest wall through a biologic process called remodeling. The bars and the forces of the bars literally reshape those cartilaginous ribs in the front of your chest, and in so doing create a more normalized chest wall that then functions better when the patient wants to be active. So it's really a life-altering procedure that I've been doing and the world's been doing for about 20 years. The role of anesthesia is absolutely critical, and it's really anesthesia right through critical care that gives a continuum of medical care that's absolutely necessary for the patient to safely get through a Nuss procedure. And we are so blessed with the very best in anesthesia care at the Valley Hospital. And we have a group of pediatric and adult anesthesiologists that have made a serious commitment to our program and provide the very best of intraoperative care, which then seamlessly joins up with our critical care attending physicians and physician extenders, who then provide the necessary postoperative care in our critical care units. Yes, it does require a team to provide what I call holistic care that's necessary and really is demanded of us as providers when seeing a patient with a chest wall deformity. And it really begins with the evaluation of that patient that not only is provided by me, the surgeon, but also is provided by a group of subspecialists that I have arranged to create a team with, starting with radiology, because it's so important for the patient and the surgeon to understand the anatomy of the individual patient's chest wall deformity. An MRI evaluation of the chest and the heart is the first step in that evaluation. And we can start to see how deep the deformity is. We can assign a severity score to it, and we could also see what is the interaction between the sunken chest and the heart, specifically in the area of the heart that's being most affected by the compression and displacement of the heart by the chest wall. And then that segues to a cardiology evaluation where an echocardiogram and an EKG is performed. We make sure that the lungs are fully evaluated by the patient being seen by someone in pulmonary medicine. A pulmonologist will evaluate the patient and do pulmonary function studies. We send patients to a cardiopulmonary lab where a evaluation under stress is performed to see if we can see any physiologic effects of the sunken chest on the heart and the lungs. And then lastly, we make sure that the patient doesn't have a rare condition called a connective tissue disease or Marfan syndrome. And often patients will see an ophthalmologist to make sure they don't have any of the ocular manifestations of Marfan's disease, and they'll also see a geneticist in some selected cases. So from radiology to genetics, a patient is fully evaluated. Well, the postoperative challenges are all manageable. That's the most important thing for anyone considering the operation to know. First and foremost, it's important that anyone considering the operation, whether you're of a pediatric age, 12 to 16, or you're an adult over 21, it's extremely important that you seek medical care from an individual that does the Nuss procedure on a frequent basis and has done it over a protracted period of time. That's the best way to have the help that each patient and family requires in getting through the journey with the least amount of difficulties. Because, as you say, there are challenges along the way. The bars need to be shaped properly. The surgeon needs to know exactly where within the chest the bars optimally need to be positioned, and that all needs to be done in the most atraumatic fashion. Once that's accomplished, then the next goal is to have the patient be as comfortable as possible, especially during those first few hours and days after the operation. The operation is done under general anesthesia. We begin the management of discomfort days before the operation by pre-treating patients with medications that will help to lessen any discomfort that the patient experiences. And that continues right through the operation. And actually during the operation, I take directed steps to numbing the chest wall by using my telescope and a small little needle and some very special medicine that will literally block the nerves that run under each of the ribs that allow us to sense and feel our chest wall. By using this medicine and very specifically injecting it under the rib, you can literally numb the entire chest with this medicine that lasts for 3 to 4 days. And it's during that time when the bars are really doing the quote-unquote heavy lifting and getting the chest up into that corrected position. It's then when patients would be feeling the greatest discomfort, and using that medicine and blocking those nerves really goes a long way to making that phase of care as pain-free as possible. We also use a lot of different medications that all work together to keep the patient comfortable. And so the immediate challenge is getting patients through the operation and through that first 2 to 3 days after the surgery, where the patients are being monitored in the hospital and their most immediate needs are being met. Usually at day 3 after surgery, the patients can go home, and home for some patients means actually to their home. But since we treat patients from all over the country and literally all over the world, we have been able to create a safe and very comprehensive program for dealing with patients who are coming to us from a distance. Those patients stay in hotels that have been wonderful in welcoming our patients and keep giving them a temporary home during that week after surgery. And the patients stay close to us, come see me a few times during that week, and then they go back to wherever they've come from. And then I usually can do a lot of the follow-up virtually, and then usually once a year up to the time the bar or bars are removed, which for most people is 3 years, but in some children it can be a little longer. Reviews and office visits allow us to check back in with one another, make sure that things are continuing to evolve in an optimal way, and usually it involves a chest x-ray to make sure that the bars are in good position within the chest. And then at some point 3 to 5 years later, as an outpatient procedure, you come back to the hospital and have the bar or bars removed, and you go home that very same day. Physical therapy plays a critical role in patients' recovery from the Nuss procedure. They are there on day 1 to assist patients in moving from the bed to the chair and learning the skills necessary to move about safely in that immediate postoperative period and get patients to feel comfortable moving about and feeling empowered that they can safely move about. And then that segues into the outpatient setting, where for 3 months, the physical therapy department and the patient, using a protocol that I've developed with a physical therapy practice in San Diego, to provide a comprehensive week-by-week program of ever-increasing challenge for patients recovering from a Nuss procedure, such that from the day after surgery to literally 3 months later, patients are regaining their normal strength, flexibility, and endurance. The enhancement that a patient experiences after undergoing a Nuss procedure is life-altering. It's truly a surgical miracle in many ways, because patients come to me not only with physical limitations that affect the quality of their life, like we mentioned, shortness of breath, fatigue when exercising, and the inability to do some of the most fun things that we as human beings enjoy doing, which is being active. And that effect on one's quality of life is very profound and can be completely reversed by doing a Nuss procedure. But also, and this is very exciting and also life-altering, patients come to me with a real disconnect between how they wish to look and feel and how they actually look and feel. And that can be very disorienting and cause a lot of emotional challenges for some patients. And to be able to address the physical issues that surround the chest wall deformity, help patients recover from the psychic stress, if you will, of having a chest that doesn't look quite normal, is extremely gratifying and something that almost all patients experience. The decision to move forward with a Nuss procedure is a very, very personal decision that requires a lot of processing between patients, their families, and the surgeon who is offering the care. And that decision, I like to tell patients and families, does not involve a wrong decision. What it involves is having the information that you need to make the very best decision for yourself and your family. And that decision is based on having all the testing results that we discussed, and then having someone to walk the patient and family through what those testing results really mean, and then helping patients decide, is there reason, both anatomically and physiologically, for addressing the issues that may be the result of having the deformity, and helping them come up with the best decision for them, which may mean going forward with an operation or not. Either way, what I hope to achieve is educating the patient completely and allowing them to make the best decision for themselves and their family.